Okay. Uh, Hello everyone. This is a quick revision or quick review of respiratory system that I have tried to compile for myself and for all of my friends that need to study this topic or this system in a very fast manner. I have tried or attempted to review respiratory system in around only 20 points, and this will be very quick. Maybe I will take 45 minutes or even less than that to cover the respiratory system for you. Okay, let's start. First of all, the first point is for spirometry. There is not an exam which does not give the question spirometry. It has been asked a lot of times. So take a look about the spirometric graph. This is the spirometric graph, and if you see the first volume that we're discussing is tidal volume, which is around 500 ml, right? The second is your inspiratory capacity. Inspiratory capacity is basically your tidal volume plus the inspiratory reserve volume. Vital capacity would be IRV plus TV plus ERV. That would be your vital capacity, which is VC. RV is the residual volume, right? Residual volume. So let's take a look about some important definitions and some values. Okay. Uh, the volume which is left in lung after normal expiration is basically your FRC, your functional residual capacity. Volume left in lung after your forceful expiration is your residual volume, right? So even after expiring forcefully, the volume is left that is called as your respiratory, the residual volume. Forceful inspiration plus forceful expiration के बाद जो volume बचता है, the capacity is called as your vital capacity. Now let's look at this image. This is your spirometry image, and the pulmonary function test that you call. So there is a patient which has a nose clip, and this is a spirometer. This is the attendant or the doctor which is measuring your lungs airflow. Now spirometry cannot measure residual volume, FRC and TLC, right? So residual volume, FRC, TLC cannot be measured by spirometry. Okay, that's all for the first point. Now let's take a look at the obstructive and the restrictive type of disorders, which is one of the most core topics of respiratory system, right? This is very conceptual to understand. Now obstructive diseases, please remember residual volume, FRC and TLC. These are the volumes and capacities which are increased in obstruction, right? Which are increased in obstruction. Why? Because there is air trapping. Right? There is air which is trapped, right? So when the air is trapped, there is more residual volume, and definitely the FRC and TLC will also be increasing. Now for restrictive type of disorders, all of these values RV, FRC and TLC would be decreasing, right? Would be decreasing. Now what is FEV1? FEV1 is basically your, yes, the volume which is expired in 1 second. So the normal value of FEV1 is more than 80%, right? Let's look at the ratio, which is very important. So FEV1 upon FVC ratio, it is more than 70%, which is your normal value. Now in restrictive pattern, again we saw that there is a decrease in RV, FRC and TLC. FEV1 would be normal to decreased. FVC would be very low, so there is a low, you know, FVC. Now the ratio would be normal to increase. That is the important point. The ratio would be normal to increase. Okay. In restrictive type of disorders, we will definitely look at the examples. Before that, in obstructive pattern, there is a decrease in FEV1, right? The lungs take more time, right? The lungs take more time. There is trapping of air, right? So the function, the time taken for expiration of, in 1 second, it is increase. FEV1 would be decreasing, right? FVC would be normal to decreased. FEV1 upon FVC would be very very low, which is less than 0.7. So if you need to remember only two things about this point, which is the second point, you remember that there is FVC would be normal to decrease in obstructive disorder, and in restrictive pattern it would be a very low FVC. Okay. Now in restrictive pattern, the examples are ILD, fibrosis or pulmonary edema. We already know that. This is a basic concept. The obstructive pattern, in obstructive pattern we have a low FVC. How to remember? O is there in obstructive and there is a low FV1 upon FVC ratio. The examples include your COPD. Again, the COPD, they have two modalities, which is emphysema and chronic bronchitis. So the DLCO pattern, let's look at it very quickly. DLCO pattern would be decreased. DLCO would be decreased in emphysema, and it would be a normal value in chronic bronchitis. Okay, DLCO, Yes, diffusion lung capacity of carbon monoxide with normal ratio, it is in DLC or decreased, along with a normal ratio of FeV1 upon FEC ratio, that would be your PAH, which is pulmonary artery hypertension. We'll be taking a look at PAH in the next point. Okay, now let's look at this graph, which is very important. Hannah, it has also been asked. Now always remember this concept that whenever you look at a graph which is a respiratory graph, you see there is the upper graph, which is like this, and this is your lower graph, right? So the upper graph would be giving you or expressing the expiration part, and the lower part would be the inspiration part. Okay, this concept would be very important. So now the blue graph that you see right here, this is your normal graph, right? So normal graph is like this, in which there is a triangular shaped expiratory pattern, and there is inspiratory pattern like this in the below. Okay, like this is your inspiratory pattern. Now what happens in obstruction is said when there is a scooped pattern. There is a scooped pattern, right? This is your scooped pattern, like this is your scoop pattern, right? So that is your scoop pattern. And in case of restrictive disorders, there is a decrease in volume. So this is what you see, this is your restrictive pattern, right? So there is a decrease in the volume. If you see, this is your volume, right? This is definitely less than the normal, and that is your restrictive pattern. Okay, so that is a low volume curve, what we call it as a low volume curve. Now that this is a question that was asked. Now in this graph, you see there is a, that is the normal or a fixed airway obstruction, right? So this is the fixed airway obstruction graph, right? This is your expiration and this is your inspiration graph. So expiration and inspiration in fixed airway obstruction. In variable extrathoracic obstruction, there would be an alteration. What would be the alteration, right? So in inspiratory, when the inspiratory graph is flattened, there is an extra thoracic obstruction, and the expiratory flattening is there, you observe you have an intra thoracic obstruction. That is the graph. Okay, now oxygen dissociation curve is one of the most important point. Apart from that, in oxygen dissociation curve, we need to remember the left shift, the right shift. What about the myoglobin changes, Bohr effect, Haldane effect, chloride shift, or the Hamburger phenomena? Okay, let's look at this very quickly. For oxygen dissociation curve, we already have read that there is a right shift in which there is a decreased affinity to oxygen. So in any cases of hyperthermia, hypercapnia, hyperacidosis, so there is more hydrogen ion which is accumulating. In case of exercise or thyroid or in altitude, right, there is a right shift because the right repels oxygen. For the left shift, left loves oxygen, so there is more affinity to oxygen in the left shift. And you need to remember there is decreased 2-3 dpg levels, which stimulates the left shift of the oxygen dissociation curve. Normally the oxygen dissociation curve is sigmoidal. It is a sigmoidal graph. And you see there, in case of a myoglobin, when you talk about myoglobin, it is a hyperbola. Yes, this hyperbola, that is the question. Let's talk about Bohr effect and Haldane effect in a simple manner. In cases of when the pH is low, and if there is hypercapnia, there is more partial pressure of dioxide. Carbon dioxide helps oxygen leave the hemoglobin. That is the most simple point, right? That is the simple point, which is Bohr effect. And there is reduced affinity of oxygen, and there is a right shift. Okay, 3 points. Carbon dioxide helps oxygen leave hemoglobin, reduce affinity of oxygen, and right shift. Now, Haldane effect. When the partial pressure of oxygen increases, there is a CO2 delivery which also increases. That is called as your Haldane effect. Simple. Okay. Now, what is chloride shift? We already know that whenever there is a CO2 which is getting transported, there is a chloride shift that happens. So the chloride, this is the RBC, the chloride jumps in the RBC, and that is called as a chloride shift. This happens in relation with the bicarb ion which leaves the RBC. That is called as your Hamburger effect or a chloride shift. Now let's look at some graphs which are important. What are we left with? Yes. So there is a graph which is 1, 2, 3, and 4. Let's look at the first graph. The first graph is basically your Biot's breathing. Yes, there is a alteration of breathing in one pattern, and then there is complete apnea, complete cessation of breathing. This is called as a Wyatt's breathing. Kussmaul's respiration. In Kussmaul's respiration, there is increased depth of inspiration and expiration. In Cheyne-Stokes breathing, there is a decrescendo type of breathing pattern along with apnea in middle, and this is what is called as your hysteresis loop, right? So ऊपर वाला हमेशा expiration, जो नीचे वाला है हमेशा inspiration, and this is your volume upon P curve. So Boyle's law says that pressure is inversely proportional to the volume. This is called as your hysteresis loop. Okay, now lung compliance, the only formula you need to remember is the change in volume upon change in pressure. That is your compliance of the lung. It is decreased in fibrosis, it is increased in emphysema. Okay, emphysema में there is trapping of air, correct? So the volume would be increasing, emphysema में compliance increase होता है. Fibrosis में there is fibrosis in the lungs, the lungs are not able to expand, so the change in volume would also be reduced. That's why the compliance will also be reduced. Okay, now 6 point, some one-liners in the question. So maximum airway resistance is by medium-sized bronchi. Okay, maximum medium. Okay, first 16th airway generations are your conducting airway type, and they form the anatomical dead space. It is around 150 ml. Okay. Now in apex, so if we draw the lungs like these, in the apex part, this is the apex, this is the middle lobe, this is the lower lobe. In the apex part, there is a decreased or the least perfusion which happens, and there is a maximum V by Q ratio. V by Q ratio is very important, and V by Q ratio is basically your ventilation perfusion ratio. Okay, now the resistance is inversely proportional to the fourth power of the radius. Okay, that would help you to solve a question which is based on the resistance of the airways. Okay, now let's look at a graph which is basically telling you the normal V by Q ratio is basically 0.9, right? Which is this point here, right? And if we talk about COPD, there is less ventilation which is happening in COPD or bronchial asthma. So this is the point which expresses your COPD or asthma. So there is decreased ventilation. Okay. Now two reflexes, very very important physiology questions. Two reflexes, which is your Herring-Bruder reflex and your J reflex. Herring-Bruder reflex is basically by myelinated vagal fibers. That is a question. So myelinated fibers, Herring-Bruder reflex, it inhibits further inspiration. So whenever there is lungs which are increasing, they are taking up oxygen, ठीक है, अंदर, उसके बाद there is a stretch reflex, and stretch reflex inhibits further inspiration. That is your Herring-Bruder reflex. Let's talk about J reflex. J reflex is nothing but whenever there is increase in the capillary pressure, there is three things which happens. There is apnea, there is bradycardia, and there is hypotension. Okay, so J reflex is whenever there is increase in the capillary pressure, there is apnea, bradycardia, and hypotension. Now let's look at some more formulas and physiology points. Minute ventilation. Minute ventilation is basically respiratory rate into tidal volume. Okay, respiratory rate, if it is around let's consider 20, and tidal volume is around 500, you multiply that and you get a minute ventilation. Alveolar ventilation, it is basically respiratory rate into tidal volume minus dead space volume. Tidal volume minus dead space volume. Okay, that is the difference between the alveolar ventilation and the minute ventilation. Now this is the very famous formula. So one hemoglobin carries 1.34 ml of oxygen. Yes. Okay, now very very important two questions. In carbon monoxide poisoning, what happens in in cyanide toxicity, what happens? Carbon monoxide poisoning, there is a anemic anoxia. Because there is a decrease in PO2. Now what happens in your cyanide toxicity? In cyanide toxicity, there is a histotoxic anemia. Everything, the PO2 is also normal, every modalities are normal, but there is, because the tissues cannot absorb oxygen, there is a histotoxic type of anemia or anoxia. Okay, now let's take a look at now altitude physiology and deep sea physiology, and also some important points. Okay, what is haze? Haze is your high altitude cerebral edema. High altitude cerebral edema. Whenever you go by the top of the hill, you experience headache, nausea, dizziness. Why? Now, and what is the physiology? Now, this happens because of cerebral vasodilatation, right? A question. Cerebral vasodilatation, not vasoconstriction. How do you treat it? By dexamethasone, steroids, and oxygen therapy. High altitude pulmonary edema, HAPE, which happens because of pulmonary vasoconstriction. In the lungs, there is constriction of the vessels, and this is why you have HAPE. Now, in cases of positive G, which is positive gravitational force, you experience something called as blackout. It is due to decrease in the cerebral perfusion. Okay. Important point is about the Caisson's disease or the decompression sickness right here. Okay, in Caisson's disease or decompression sickness, there is a treatment which is hyperbaric oxygen therapy. It is because of nitrogen bubbles in your blood. Okay, nitrogen which is entering. Okay, also called as your decompression sickness or Caisson's disease. Okay. Now, two more points for the completion of physiology part. Now, this is your very simple annotation of your regulation of respiration. Let's study regulation now. Regulation now. Three things. Okay, three things. Pons. Okay, mid pons. This is your medulla. Okay. Now, we will studying four lesions. Okay, 1, 2, 3, and 4. The first lesion is above pons. Pons के नीचे क्या होता है? PNC, which is your pneumotaxic center. Okay. What will happen if there is above pons lesion? There would be increase in the depth of inspiration. Just remember this. Okay. If there is a lesion below the pons, okay, below the pons or mid pons, mid pons, there is an inspiratory spasm. Okay. If there is a pontomedullary lesion, there would be an irregular breathing or irregular breaths, which is also called as your apneusis. Now, let's study pneumotaxic center limits inspiration. Apneusic center is the opposite of that. Now, this is your DRG and the VRG, right? This is your DRG and the VRG. Okay. Now, this is your PBC. What is PBC? Yes, this is the pacemaker of respiration, also called as your pre-Watzinger complex. If this is destroyed, the automated breathing is lost. Now, if there is a lesion, below the medulla, right? This is the breathing just stop. So there is a cessation of breathing, right? So this is a very simple annotation, simple concept of the regulation of respiration, in which we also need to remember the points like the central chemoreceptors. Yes, in brain there is a central chemoreceptor, and in periphery there are different chemoreceptors. In central chemoreceptor, you know there is a stimulation by PaCO2 and H plus level only. But in peripheral system, the peripheral chemoreceptors can be triggered by, most importantly, by hypoxia, right? Now, OSA, it is nothing but your obstructive sleep apnea. You can find a keyword of daytime sleepiness, and you will do a study which is called as your polysomnography. Okay. Now, what are the types of respiratory failure? 10th point, types of respiratory failure. There are mainly 4 types of respiratory failure, in which most important are type 1 and 2. How to differentiate between type 1 and 2? Type 1 is basically hypoxemia, hypoxemic type of respiratory failure, in which there is decrease in the PO2, and it leads to pulmonary edema. Okay, pulmonary edema or ILD. Okay, ILD. Now, for type 2 respiratory failure, we will be seeing the CO2 level, because it happens due to hypercapnia. It is happening due to hypercapnia, increase in the PCO2 levels. It leads to you can see type 2 respiratory failure in hypoventilation, in your obstructive sleep apnea, and also in your COPD. Okay. Type 3 is perioperative. This can be a one liner or a question, and after you see there is a case of shock and there is so much of hypoperfusion, it is a type 4 respiratory failure. Okay. Now, let's talk about ILD. ILD is basically your interstitial lung diseases. And if you see there is a honeycombing pattern, there is a traction bronchiectasis, and they are saying that the lower lobes are involved. The lower lobes are involved. it is nothing but your it is nothing but your ILD, which is your interstitial lung disease, specifically UIP pattern or your IPF pattern. These are your most common type of interstitial lung disease. Okay. Now, there will be a decrease in FVC ratio, but if you see there is a GGO pattern, there is a ground glass opacity pattern, you think of NSIP pattern, which is non-specific interstitial pneumonia. If you see they mention GGO plus centrilobular nodules, you think of hypersensitivity pneumonitis. Okay, so honeycombing is UIP pattern, GGO is NSIP pattern. If you see there is GGO plus centrilobular nodules, there is a hypersensitivity pneumonitis. Now let's look at some images. What are these? This is your HRCT. Okay, HRCT is your investigation of choice, right? Investigation of choice in case of ILD. You see these are the pattern which are associated with your honeycombing, right? These are all the honeycombing patterns. This is a honeycomb pattern. Okay, now what is this? This is your meniscus sign. This is your meniscus sign which you see in pleural effusion. So let's mark it. This is your pleural effusion. What are these? What is this chest X-ray? You see there is a bilateral whiteout lungs picture. When you see bilateral whiteout lungs, this is nothing but a picture of ARDS, acute respiratory distress syndrome. Now let's look at these. What is this? This is a chest X-ray which is showing consolidation. Yes, consolidation in the right middle lobe. Right middle lobe is nothing but your pneumonia, or you can say there is COP. Okay. Okay. Let's talk about pleural effusion, ARDS, pulmonary embolism, PAH, pneumonia, asthma. Okay. All right. Pleural effusion. What is the trick to remember? What is the criteria of pleural effusion? You see, there is a Lights criteria. There is a Lights criteria for pleural effusion, in which you can remember the points by simply two things. Okay? PL for pleural effusion, P and L. You need to remember these two alphabets. P stands for protein, L stands for LDH, right? This is very simple. P upon S, so pleural fluid ka protein divided by your serum protein more than 0.5, or LDH, again P by S ka ratio more than 0.6, or your pleural LDH which is more than 2/3. If any of these is plus or positive, you see the pleural effusion is basically your exudative type of pleural effusion. So again, protein LDH, or your protein or your LDH which is more than 2/3. So you need to remember only P and L. If you remember these two alphabets, you can remember all of the criteria for lights. Okay. Now, when do you say that it is an exudative type of effusion? Whenever there is inflammatory fluid, there is neutrophils. Yes, there is inflammation, right? So in TB, in pneumonia, in kind of malignancies, you can have an exudative type of effusion. On the contrary, your transudative type of effusion is you see in your cardiac failure and your cirrhosis. Now, when will you drain the fluid? It is in the cases of low glucose or pH which is less than 7.2, or if there is localization. Whenever see there is a localization in the lungs, always need to drain the fluid. Now, whenever you see there is a milky appearance of pleural effusion or the pleural fluid, it is suggestive of chylothorax. The TG values, the triglyceride values are more than 110. Now, you already saw the picture of ARDS like this. This is the chest X-ray of ARDS. Okay. Now, what is ARDS? It is acute respiratory distress syndrome. Now, we have a modified Berlin criteria. Modified Berlin criteria for ARDS. Whenever you have these words like the patient is in sepsis, or the patient came with complaint of pain abdomen, you diagnose it as pancreatitis. Now he has deteriorated. Now, toxins. Okay. So what is the modified Berlin criteria? We have 4 points. Okay. So 4.1, 2, 3, and 4. First point is PaO2 upon FiO2 which is less than 3. okay, less than 30. Now clinical features which is appearing within 1 week, okay, we have a bilateral opacity. We already saw that in our chest x-ray. Okay, PCWP which is normal, pulmonary capillary wedge pressure which is normal. Okay, in ARDS we also call it as a non-cardiogenic pulmonary edema. Yes, this edema or this collection of fluid is non-cardiogenic. It is not due to heart, it is not due to heart, it is due to the lungs, you know? Right. Now for the treatment of ARDS, very important point is we will increase the PEEP. We'll increase the PEEP, which is positive end expiratory pressure. It's around 5 centimeters. Low TV ventilation we will prefer. Minimize the acidosis, and we also will consider diuresis. Okay, just to remove or flush out the fluids. You see, if there is a bat wing appearance, yes, it is a. If there is a bat wing appearance, if there is a bad wing appearance in the lung or in the chest X-ray, it is suggestive of your cardiogenic type of pulmonary edema. Okay, it is a cardiogenic type of pulmonary edema. Now, let's talk about pulmonary embolism. Patient with pleuritic chest pain, sharp pleuritic chest pain. Okay, pulmonary embolism. Along with that, we will do points of DVT, which is deep venous thrombosis also. So there is a Wells score. There is a Wells score in DVT. Now, if that Wells score is more than 4, there is a chance, or there is definitive chances of your pulmonary embolism. We will go ahead and do a CTPA, which is CT pulmonary angiogram, and you see there are filling defects. It is suggestive of pulmonary embolism and nothing else. If the Wells score is less than 4, you will think that may or may not be pulmonary embolism, and you will go ahead and do a D-dimer, which is the most sensitive test for pulmonary embolism or DVT. If the D-dimer is negative, DVT or PE has definitely been ruled out in the case. Okay, now, there is a triad of virtuous triad. Okay, there is H, hypercoagulability, vascular stasis, and endothelial damage. This is your virtuous triad. Okay, you need to remember this. Now, if you see the image like this, which there is a instrument which looks like these, it is nothing but your IVC filter. Okay, IVC filter. In ECG pulmonary embolism mein, you can have S1Q3 or T3 type of image. You have a very common sign, which is your tachycardia, RBBB type of pattern. Okay, you can see all of these. Now in echo you can have RV strain, or RV free wall hypokinesia. Chest X-ray, you see a Hampton's hump. It is a wedge-shaped hump. It is a wedge-shaped hump or a wedge-shaped opacity. It is a wedge-shaped opacity. You need to look very. Okay, so it is a wedge-shaped opacity. Now, for treatment, in stable cases, you can proceed with LMWH. If contraindicated, you can have your IVC filter. Okay. Now, if the patient is unstable, definitely we will go on and break the clot by fibrinolytic therapy, or contraindicated agar hai ye, then we will go for embolectomy. Yes, retrieval of the embolus. All right. Now we have 14th point, which is pulmonary artery hypertension. Pulmonary artery hypertension, the pressure is more than 25 millimeter of mercury. DADO is basically the drugs which are used for pulmonary artery hypertension, and then we will go for acute vasoreactivity testing. Okay, more important point of pulmonary artery hypertension are the drugs which are being asked again and again. So we have endothelin receptor agents, which is entans, so embrisentans. Yes, entans, embrisentans. Hepatotoxic drugs. Okay, we have PDE5, phosphodiesterase E5 inhibitors, which are basically fill drugs, sildenafil, tadalafil. They are contraindicated with nitrates. Now we have guanate cyclase agonist, which is your Riociguat. Okay, you have Celexipac के नाम में है, which is prostacyclin agonist, which is a oral drug. Now a question here. Now let's talk about pneumonia. 15 point is pneumonia. Very very important. You think of curve 65 score, or which is updated to form CRB 65 score. Again, C stands for confusion, U stands for urea, R stands for respiratory rate and B stands for blood pressure. Now confusion, you get 1 point. Urea, BUN more than 7, 1 point. Respiratory rate more than 30, 1 point. SBP or systolic blood pressure less than 90, 1 point. Now why is curve 65 very important? Curve 65 is the criteria uh, which is based or which is implied for the treatment. How do we treat? If the patient is admitted or not, what is the criteria to decide it is curve 65? Okay, so if the score is 0 to 1, it is an OPD based management. We give amoxi plus our macrolide. So macrolides include your azithromycin, right? These type of drugs. IP or inpatient admission you do when the score is true. Okay, so you use beta lactams or fluoroquinolones along with your azithromycin. Now when will you admit the patient in the ICU? When the score is more than or more than 3, you will definitely consider admission in the ICU. So you will start with beta lactams or fluoroquinolones or your azithromycin, which is azithromycin. Now some one liners for important diseases. Now ABPA, what is ABPA? It is allergic bronchopulmonary aspergillosis, have a hand and glove type of appearance. You have monad sign in again aspergilloma. You have a halo sign. You have a halo sign in invasive type of aspergillosis. You have reverse halo sign in mucormycosis. Very important question. Mucormycosis you treated by voriconazole. Okay. Now let's talk about asthma. Asthma is one of the important topics in which there are so many updates. I have tried to compile all of these things in just this area. Right now, asthma is basically your reversible type of airway constriction. So airway is getting constricted, but it can be reversed. So two important points, only two important points then you need to remember is that the drug of choice for asthma, these are your beta agonist like your short acting uh, beta agonist, and then there are long acting beta agonist, which is your formoterol. The mainstay of treatment for asthmatic patients, these are your glucocorticoids, right? You must have heard about budesonide. Budesonide is your glucocorticoid. Okay, now let's look at the symptoms and the treatment of asthmatic patients. Less than 5 days a week, if you have the symptoms, you have to go with low dose ICS, which is inhalational corticosteroids. Now along with formoterol, which is SOS, है ना? Whenever you need formoterol. Now if more than 1 week, you have again low dose ICS and formoterol daily. All right, if it is decrease in the lung function which you observe, we change it to medium dose ICS plus formoterol. Now the step 5, we already have done 1 2 step 3 step 4. Let's talk about step 5. We had LAMA plus HDICS, which is high dose steroids and anti IgE agents. Okay, so this is your protocol for treatment of asthma or asthmatic patients. Let's talk about the update is basically your MART. Now IgE, IG4, IG13, IL5, IL5 R receptor के कौन से ड्रग्स होते हैं? IgE5 is basically omalizumab. IL4 is dupilumab. IL13 is tralokinumab. IL5 inhibitors are mepolizumab and your risolimab. Okay, reslizumab. Benralizumab has been asked. Okay, it is your IL5R alpha. So it is a receptor. Okay, it is a receptor for your IL5, and that is inhibited by benralizumab. Okay, these are the drugs. Now let's look at some images. Okay, in this page we'll be discussing carcinomas, we'll be discussing COPD, we'll be discussing emphysema. Okay, now this is your picture of lung carcinoma. We will having a discussion of lung carcinoma ahead. Now what is these? What are these two pictures? These two pictures are your correct COPD. Okay, chronic obstructive pulmonary disease. What are these? You see there is a tubular lung. There is a tubular lung. A tubular lung, right? This is basically your COPD. Okay, now what is this? This is your dilated. These are your dilated airway, and this is a picture of your emphysema. This is your emphysema. Okay, now Let's look at some most important theory points of COPD, and we will discuss the contrast between chronic bronchitis and emphysema. Now, COPD सबसे पहले let's look at the goal criteria. ठीक है, let's look at the goal criteria because it has some values. We just have to remember 80, 50, 30. So goal criteria, it takes into account your FEV1 value more than 80%, 50, 30 to 49, and less than 30. Okay, let's talk about exacerbation. So we have, again, there are four. Okay, four stages that you see. Okay, 4 points that you see on goal criteria. Exacerbation. In exacerbation, if there are more than two exacerbations, you go ahead with using LAMA or LABA or ICS. LAMA is basically long-acting muscarinic agonist, long-acting beta agonist, and your inhalation corticosteroids. If the exacerbations are 0 or 1, okay, you go on with using SABA or SAMA or LABA or LAMA. Okay. Now, what is Reed's index? Reed's index is basically if this is the, okay, if this is the thickness of the overall membrane. Now, है ना, you just focus on this thing, which is your mucus layer. Now, if we talk about the Reed's index, it is basically A upon all of these. So A upon B, right? So it is A upon B. If it is more than 40%, it basically indicates your chronic bronchitis. Now, let's look at the differentiating features of chronic bronchitis and emphysema. Now, chronic bronchitis, what is definition? You have to have cough, just a persistent cough for more than 3 months per year for more than 2 years. 3 months per year for more than 2 years. Okay? It is a type 2 respiratory failure. You will have to remember the blue bloaters because there is cyanosis. There is cyanosis. Okay? Type 2 respiratory failure, if you can remember, we saw that it is hypercapnia. Okay, it is hypercapnia. Now, emphysema, you have to remember it is type 1 respiratory failure. It is due to hypoxemia. You see there are pink puffer. It has a pink puffer appearance. Okay, so centrilobular is basically your upper lobe involvement. Centrilobular emphysema mein there is upper lobe involvement and smoker. Right? These are the 3 points: centrilobular, upper lobe, smoker. Paraseptal emphysema. If there is bulle, which is there in paraseptal emphysema, the bulle can rupture. It can form spontaneous, yes, spontaneous, or what you call as a primary pneumothorax. Very, very important point. Okay, smoker, centrilobular, upper lobe, paraseptal, bulla, spontaneous primary pneumothorax. Now, what is the treatment for acute exacerbation of COPD? Already known case of COPD tha, and he comes to you for difficulty, acute difficulty breathing. You will administer oxygen, antibiotics, plus short-acting muscarinic agonist, okay, for treatment of your acute exacerbation. This is all about your COPD. Yes, we have done chronic bronchitis, emphysema, and we have also done the definitions along with goal criteria. Done. Now, we are approaching the end of the lecture by only 3 points. So, 3 most important topics: occupational lung diseases, CA lung, right, and your CPAM. Okay, most of the questions would be on these 2 topics, which is your occupational lung diseases and your malignancy of lung. Okay, now let's look at the point 18th, which is about the occupational lung diseases, right? Now, whenever you see there is axial calcification, there is PMF. What is PMF? It is progressive massive fibrosis. This is the third stage of silicosis. Okay, it represents silicosis. Okay, what is Kaplan's? Kaplan is basically CWP plus RA. So it is Kohlbacher pneumoconiosis plus rheumatoid arthritis. Okay, what is Erasmus syndrome? It is CWP plus systemic sclerosis. This can be a question, right? Now, what is this? What is the X-ray right here that you see? This is a X-ray of asbestosis. Why? Because it is a holly leaf sign. This is what you call as a holly leaf sign. It has a sharp pointed end like these, and so you have a picture like this. So this is your holly leaf sign. Okay, let me erase it. Okay, so holly leaf sign, we remember it as asbestos. The question would be saying about the shipyard industry. Shipyard industry, and you will see there is a pleural plaque that is mentioned. So that is your asbestosis. Okay. Whenever you see or whenever you hear a word of frozen hemithorax, you are thinking of malignancies, most commonly adenocarcinoma. Okay, so either you can have a short or a stubby microvilli in your electron microscopy, or you can have a long slender microvilli, right? And long slender will tell you about mesothelioma, in which there is chororetinine and CK56 positivity. Okay, now let's look at the most important point of the lecture, which is your CA lung. CA lung is basically very, very important. It has been the most tested topic of the system, in which they can ask you about the mutation. They can ask you about an image. It can be an X-ray based question, right? Mutations are one of the most importantly asked question. Let's look at the CA lung topic very easily in a very simple way. So if you ever see the word smoker in CA lung question, you think of two things, which is small cell cancer and your squamous cell cancer. Small cell cancer, it is due to it involves the central lobe. Okay, now यहाँ पे every word starts with S, smoker, small cell carcinoma, central, SIADH. SIADH is basically a paraneoplastic syndrome, right? Now, synaptophysin, chromogranin, and NSC. Now, for esopard effect, we can remember esopard effect. So it is SS. So everything is S. If everything is S, it is about a small cell carcinoma. Now, males are more commonly involved in small cell cancer compared to females. Okay. Now, squamous cell carcinoma, it is P53 mutation. Okay. You see there is keratin pearls, right? This is your keratin pearls. Now, also there is hypercalcemia. Hypercalcemia is the PNS of your squamous cell carcinoma. Okay, so we are done with small cell carcinoma and squamous cell carcinoma. Now, if the patient is a non-smoker, if she's a female, now you think of adenocarcinoma, you think of KRAS mutation, ALK mutation, and your EGFR mutation. How to remember this? A for adenocarcinoma, you have A in KRAS, you have A in ALK mutation. Also, if you talk about the markers, you see that A is your first alphabet, alphabet number 1. So you can remember TTF1, napsin A, right? So this is your trick to remember your adenocarcinoma. It has a lipidic pattern. What is lipidic pattern? Lipidic pattern is basically if we have lobules, like these, that is the branching. The tumor cells are arranged in a pattern like the butterfly, like these, so it is a lipidic pattern. Okay, it's a lipidic pattern. Okay, now what is this X-ray? What do you see here? This is the X-ray showing a consolidation. No, it is a solid tumor. It is a solid tumor in the upper lobe, in the right upper lobe, like this. Okay, and the patient is telling, or you have the words like Horner syndrome is there. Yes, you think of Pancoast tumor. In which the MRI is the investigation of choice. Okay? Before reaching the 20th point, let's look at the image of carcinomas. Now, this is your adenocarcinoma. We already studied this. This has a lipidic pattern, right? The butterfly in the fence pattern, or the lipidic pattern in adenocarcinoma. This is your small cell carcinoma. You see SOPARD effect. Okay. This is your squamous carcinoma, or squamous cell carcinoma. You see this is your keratin pearls. These are your keratin pearls. Okay. This is all these are your keratin pearls. This is your carcinoid tumor, the neuroendocrine type of tumor. Now, large cell carcinoma. One point about large cell carcinoma, you can think that the male has large breast. So large breast means gynecomastia. So large cell carcinoma का paraneoplastic syndrome है gynecomastia. Okay, now this is mesothelioma. This is a picture of mesothelioma. You can have a look at all of these images. So adenolipidic, okay, squamous cell, keratin pearls, carcinoid, small blue cells, small cell carcinoma, SOPARD effect. This is your large cell carcinoma, and then this is your mesothelioma. Okay, now coming to the last point, which is about a topic which you have read in pediatrics, which is your this X-ray. Okay, what do you see? This is your multiple cystic pattern. Okay, multiple cystic pattern. Okay, so multiple cystic pattern you see, and the diaphragm is okay here. Okay, diaphragm appears good, so that is, it is not cda, it's not cda, it's not hernia, it's not diaphragmatic hernia. So what do you think of? You think of cpam. So cpam is your congenital pulmonary airway malformations, airway malformation. Chest x-ray will show multiple cystic appearance in the lung field. Now three important points. When do you say there is massive hemoptysis? When there is more than 400 ml per day. Okay, what is the investigation? First you will do chest x-ray, then it will be followed by CCT, and it will be followed by BAE. What is BAE? Which is our bronchial artery embolization. Okay. Third point, and the important point, which can be a question, that you don't have to mix during the treatment of cough. You don't have to mix antitussives and mucolytics. Okay, so this was all of the respiratory system, right? This was all of the respiratory system which has been revised, right? So it has already been 45 minutes, 46 minutes, yes, and you have revised all the RS system in that. So I hope this would be a helpful video, and let me know what can be improved. And yes, I have not included the topic of tuberculosis because it is a huge topic to revise in a single video. Okay, so I hope that helps. Okay, thank you.